Welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Stephanie Estima. She is a doctor of chiropractic and also the host of the podcast Better with Dr. Stephanie. So, Steph, welcome to the show.
I'm delighted to be here. Thank you.
Well, I definitely want to chat with you about a lot of different issues. Definitely want to focus more on women's health today. But before we get started, can you give the audience a little bit of a brief background about yourself?
Sure. Yeah. So as you said, my training is in chiropractic. So I went to the Canadian Memorial Chiropractic College. Shout out to class of 2003. Before that, did my undergrad in neuroscience and psychology. And I've just always been enamored with everything brain, brain metabolism, how the descending and ascending sort of communication between brain and body, and I've integrated that into, I was in private practice for 16 years and then moved from in-person sort of brick and mortar practice to more of an online. We have online courses and I teach other doctors and practitioners now on female specific protocols. And as you mentioned, I also host a podcast. I'm an eternal learner. So I get to speak to some of the what I would consider thought leaders in nutrition and fitness and mindfulness and what it means to live what a well-lived life looks like. So I get to learn a large swath of bodies of work, which keeps my learner archetype really happy. And now I've really honed in to working with women, and specifically women in perimenopause, because it is a very underserved community or vertical, let's say, in the arc of a woman's life. When a woman wants to get pregnant, there's lots and lots of options. There's lots and lots of avenues that she might think about. When she gets into perimenopause, she's often told, well, it's just a part of aging, suck it up, or here's a birth control pill, or, here's an antidepressant or whatever it is, rather than really recognizing the cluster of symptoms that often can occur with some of these hormonal and metabolic and physiological changes for females. So I guess my actual title is a women's health educator, because I want women to not misinterpret their experiences when they get to perimenopause. They're like, oh, heart palpitations, or, oh, I have more anxiety, or, oh, I'm more sensitive to sound. I'm not crazy. Those are just sort of a natural function of aging and a natural function of some of the changes that are happening in a female body at that point in her life.
Okay, excellent. Well, yeah, you kind of answered my next question, because I was going to ask you, why did you get into women's health, specifically? And it seems to me that you've kind of like identified this gap in women, like perimenopausal women in particular, who may be getting, particular symptoms that are not always maybe addressed appropriately by, standard healthcare, or they maybe not be able to offer all the treatments, say, that you want to offer some of those patients. That's kind of what it seems like. So do you find that most of your clients then are probably, between the ages of like 30 to 50, where they're sort of, experiencing some female difficulties, you could say, but they're not, in menopause?
Yeah, I would say the large majority of my audience is somewhere between 35 and 52. That's sort of the main demographic. That's the main demographic of people who listen to my podcast, main demographic, even of the health coaches and doctors that I'm training. It's usually the doctor who she herself is having issues in perimenopause and she wants to fix her own health issues and then be able to serve her patients, let's say.
I think
So I
that's an excellent approach too, because once you know how, if you can identify or relate to how, your patient is feeling, like I think the patient almost feels that. And I think that just through, having that experience yourself, you're just to be able to deliver better healthcare overall. So
I think empathy is a lost art in medicine, and I would say in patient care and generally, like, women are not, and patients, gender agnostic. Like, we're not just numbers, we're not just a bag of clinical symptoms. So I think that if there's some empathy and some love and some dare I say humanness that we can infuse into our patient care, I think I think that's more enjoyable for the doctor. We won't see as much burnout. And then that's also, the patient is going to just get, or like, her care, or who, the patient's care is just going to be better.
yeah, and I totally agree. And I don't want to go too much off on a tangent, but with regards to like burnout, like, if you're working 50, 60 hours a week, but you love what you do, it doesn't feel like work and you
You'll
don't
never
get
work a
burnt
day in
out.
your life if you love what you do. Yeah, you come home.
Exactly. But if
Yeah.
you're like working really hard, even if it's only like 20 or 30 hours a week at something, like that can actually burn you out. So I just wanted to make that quick point before we kind of got into women's health, because burnout, it does seem to be a bit of a hot topic in healthcare these days. You know, a lot of people are discussing it.
Yeah, and I know we want to get into a kind of women's health and all the juicy things there, but it is very true. I think a lot of healthcare providers, particularly nurses, even we saw this in the beginning of the pandemic. We were clapping for them every sunset, and every at 6 o'clock, everyone came out and we were singing songs, and then several months later, they were being discarded. They're being overworked, unappreciated, and probably underpaid as well.
I
So
agree.
I would say, yeah, we need to love up on our healthcare workers. They work very hard, and whether you're working in a hospital setting or you're in private practice, there's a lot of work that goes into patient care.
I agree, and we should acknowledge that. So just getting into the women's health today. So what would you say is the most common kind of symptom presentation that people, that your clients come to you with? Is it more like low mood? Is it more they're trying to maybe change their weight, or is it a combination of everything? And what is your kind of overall approach?
Yeah, I think that when we're thinking about most common, let's say, complaints or clinical presentation, it depends on the age of the patient, certainly. But I would say in my, with my, we'll call it like specialty of talking to perimenopausal and serving perimenopausal women, it often starts as, hey, what I was doing in my 20s and 30s is no longer working in my 40s. So I'm noticing that I'm gaining weight. I'm noticing that I'm not sleeping as well. I'm noticing that I'm more sensitive. Maybe I have a bit more emotional dysregulation. I notice that my body composition is changing. I'm noticing that I'm not taking as much joy in the things that I used to. And that general, just to tack on, we were talking about healthcare workers, but there's also this general feeling of feeling burnt out. A lot of women in their 40s, we sort of have I'll call it an environmental constraint where we have pressure from below and pressure from above. So pressure below is, if you're in your 40s, let's say, maybe you have a child or children who are in their teens or entering into their teen years, which anyone knows that's when the parenting really starts. Like they're really cute when they're 3 and 4, and then they're 12 and 15 and 17, and they're lippy and they think that they know everything, and they have more access to, they can drive and all these things. So there's sort of stressors in terms of children. Maybe they're having difficulties in school. They've just been through a pandemic. So maybe there's some mental health issues, or maybe they're behind academically, that kind of thing. And then there's also pressures from above. So a woman in her 40s, early 50s probably also has aging parents, or caregivers who need extra time and love and care. So maybe they need more assistance. Maybe you're driving them to doctor's appointments, specialty appointments for your parents. And so there's these kind of two constraints that we don't really see for the most part. I mean, certainly there's outliers for everybody, but a woman in her 20s and 30s usually is not dealing with a teenager and concordantly, an aging parent or a sick parent or a dying parent. So we see that there's a lot of these environmental stressors. And so when we are in this kind of state where we are, if we sort of translate that into into our physiology, we're going to be hyper stressed. When we talk about the
Mm-hmm.
nervous system, we're going to be driving the hypothalamic pituitary adrenal axis, which is just a fancy way of saying you're stressed out of your mind. You have a lot of cortisol output, a lot of adrenaline output, a lot of noradrenaline output. And then we start to see changes in her menstrual cycle. And we're also going to see changes, all the things that I just listed before: changes in sleep, changes in mood, changes in affect, emotional regulation. We're going to see some of those changes as a result of her physiology constantly perceiving threat. So I would say that that's probably where I start with most women, is like, tell me about your life right now.
Yes.
And of course, we know when you're stressed out, it makes it much harder to lose weight. It makes it much harder to gain muscle. Your recovery is attenuated. So there's all of these different sort of ways. There's almost like a, tentacles, let's say, of an octopus. You have this like these stressors, and then they just bleed into all of these different verticals of a woman's life. And she comes and she's like, I don't know why I've just gained 10, 15 pounds that I can't get rid of, and I can't sleep, and I hate everyone, So that's usually where we start, is looking at her life and the emotional support and the social structures and the social support that she has. And, we can, I don't know how deep you want to dive into this, but, we often talk about, how do you delegate? How do you ask for help? Because these are things that women are notoriously poor at. We have this superwoman syndrome where we want to look good. We want to raise the kids. We want to, we want to be doing it in heels, and we want to be looking perfect all the time, and never really being able to ask for help. Whereas when we look at generations, our foremothers and our, grandmothers and our ancestors that came before us, they were all raising children communally, right? It was like mom and grandma and aunt were kind of either in the same house or across the street from each other in the same neighborhood. And now we often see, women with parents in different, cities, if they're around, and the bulk of the caregiving and raising of the children falls on the woman. And so she doesn't have the community, let's say, rallying behind her. And and then she has a career maybe to deal with. We haven't even talked about that, but there's all of these different sort of socioeconomic, we'll say, stressors that are driving some of the metabolic mayhem and the physiological kind of dysregulation that we're seeing.
I think you make a couple really good points there. And I mean, it should almost be obvious, but I've never really kind of made this connection before. But you are correct in the fact that, like, once one approaches probably around the age of 40-ish, there's oftentimes they have the stress of kids, but then they also have the stress of their parents then getting sick.
Right.
And it's sort of like a double whammy. And then, like you said, you're not even adding, career then on top of that. And then it's just,
maybe there's a divorce,
yeah.
there's all of these different things that we see women deal with in their 30s and 40s. Yep.
Yes. And then that stress is going to, obviously skyrocket their cortisol levels. And, I've mentioned on this podcast before a few times that the higher your cortisol level goes, the lower your testosterone level goes. And, just like men, women also need testosterone for motivation, sex drive, for feeling good, all the things that men need it for. So I can,
and if can I interrupt you for a moment?
Absolutely.
I just want to double click and highlight what you just said. In terms of testosterone, we often, for women, we ascribe phenotypically the hormone for women is estrogen. We think, oh, estrogen, estrogen. But actually, and I'm sure you know this, I'm sure you've discussed this before, testosterone is actually the most abundant sex hormone in women as well, right? So to your point, it's famous for libido, which is, women need to be having sex too. It's and orgasming as well. This is so important for our physiology, but, around testosterone is really important for muscle mass, right? If you are trying to build muscle, or even just the maintenance of muscle, you said cognition, which is important. A lot of women will say in their 40s, like, I don't feel like myself anymore. Like, I feel like I'm living in this body, but my personality has changed. Part of that is testosterone changes. Testosterone helps us take risks, helps us be confident and make, affirmative or decisive, let's say, decisions. And so when we don't think about testosterone as women, I think we're missing the boat. So I just wanted to, like, it was such a brilliant point that you made. And I just felt like it was important for us to highlight that a little bit.
I kind of want to stick on that for a sec, because my next question to you on that is, do you find that a lot of women are kind of very maybe a little bit concerned and also surprised when you mention to them that, hey, maybe you should get your testosterone levels checked, and maybe we should look at, increasing that hormone? Do you find that when you mention that, a lot of women are very surprised at that?
Yeah, I don't think it really comes into the decision-making tree, right? It's as I mentioned, most people are like, is my estrogen too low? Do I need to start taking progesterone? So we understand that progesterone and estrogen play a role in our, mood, let's say, our ability to sleep, but testosterone's often forgotten about in women's medicine. And even if you go to your doctor, if a man goes in complaining of low libido, he's probably going to walk out with, maybe he's in his 40s and he may very well, it'll be easy for him to acquire a prescription for TRT or testosterone replacement therapy. It's still relatively controversial. I'm not sure why, but it's still relatively controversial for a woman to be on testosterone replacement therapy. And one of the indications, of course, is low libido.
Mm-hmm.
But if a woman comes in with some of these cluster of symptoms that we're talking about, like loss of muscle mass, and even kind of getting into sort of the gynecological realm, like painful sex, anorgasmia, like inability to orgasm, like when we talk about kind of the anatomical structures, let's say of our genitals, like part of the vagina is muscle, right? So if you don't have enough testosterone to maintain that smooth contractile muscle, it's going to atrophy. And that's going to make sex and intimacy and orgasming very, very difficult. So, and that's not just the vagina. We can talk about the vulva and the clitoris and all of that, but like testosterone, of course, more testosterone in the same way that it would affect, sensitivity for a man is going to affect, let's say the clitoral sensitivity and the strength of a woman's orgasms as well. So these are all really important things that I think were really taboo and maybe even still a little taboo.
Yeah, and I think we
About.
should be discussing them because there's a couple points there that you made that I think that are really important regarding the testosterone. So, like I know you have on your page there somewhere on your website that it's important for girls to have like certain types of orgasms kind of thing, and I may ask you a little bit more about that.
Happy to.
But one thing that I know for sure that's documented in the scientific literature is that if a woman does an orgasm frequently enough, it can decrease their tolerance for pain and they can have more pain in general. And
Correct.
I can see how that could, tie in, say, to conditions like fibromyalgia and conditions like that, where, patients are in a lot of pain and maybe they don't know, why in certain instances. And then, so if you have low testosterone and then you fix this orgasm issue, which again, I know this is a bit of a taboo subject. And there's a little bit of like hypothesis going into this, but if a woman is in fact in chronic pain, they're not orgasming, you give them testosterone and they start to have orgasms again, it is possible that you could correct, some of their underlying chronic pain just by supplementing them with testosterone and with the orgasms that hopefully pursue with that. And I should make one note too, that just having high levels of testosterone in itself can also increase your overall pain tolerance. So it doesn't necessarily make the pain go away. It's just that you're able to tolerate it a little bit better when you have higher testosterone.
Yeah. And I would say one of the things I wrote about in my book, it's called The Betty Body, is a lot of women who experience PMS, so premenstrual syndrome. So this is the week or so before she starts bleeding. Sometimes an orgasm in that week leading up will, just as you said, will improve her pain tolerance. So the tenderness, the inflammation that she's feeling is going to be reduced the more that she's orgasming. And so there's a lot of conversation on like how much and how often. And I think for women, it's like as many as you can get, it's like as much, whether it's a partner
I'm sure
or
they
it's
love
yourself.
hearing that.
Yeah. But it's really true. When we think about some of the physiological benefits of regular orgasms, you're going to have better HRV or heart rate variability, which is basically it's a measure of sort of parasympathetic and sympathetic balance. You're going to improve your blood pressure. Your blood pressure will go down. Your respiratory rate tends to go down. All of the things that we think of as vital signs tend to improve. Of course, the brain, you have more oxygen perfusion to the periphery, to the brain, all through the body. So these are all really important metrics of health. And I think that because sex has just traditionally been a taboo subject, not something that's very commonly discussed, it's really not talked about in a checkup, in a 10-minute checkup, right? With a doctor, where they might be asking about sexual health or any sort of changes. And certainly there are disciplines like OBGYNs. We have, obstetrics and gynecologists who will talk about that. But even then, your OBGYN will maybe have 5-10 minutes with you. And, you may not have either the rapport, which is kind of what we were talking about at the top of the hour, like adding in, infusing some humanness and empathy to your conversations with your patients. But maybe there's just not the time or the let's say flexibility within the constraints of the traditional medical system for a patient to be talking about her sexual health. So she turns to Dr. Google, she turns to Instagram, and it's kind of the wild, wild west. Like you can find some really good accounts and you can find some, batshit crazy ones.
Yeah, there's definitely both of them out there. And I just want to make one point too about the testosterone for women who may be, interested in getting theirs checked and have it prescribed for them. So, that is something that I do. So if you are a woman who, wants your hormones checked, always get your total and your free testosterone checked,
Yes,
because the
yes.
free testosterone is the one that's most important. So don't just ask for the total.
Yeah.
And then also to, women may not be sure how it's applied. So for women and for men sometimes too, I just use a cream. So you can get it compounded at say 0.5 to 1% testosterone, which is what I use for most women. And that's generally effective enough to treat their symptoms of low libido or whatever they are experiencing. And then again, not to get off topic, but sometimes for men, I might use like 10% testosterone cream. So again, I'm using like, 10 to 20 times the amount of testosterone for men as for women.
Which would
So
mimic the natural differences between men and women anyway, right? There's like a
yes,
10 to 20% difference, or 20x, I should say, difference between men and women. And I think that, we're talking about testosterone. So I think it would behoove me not to mention that there are a lot of lifestyle interventions as well that you can explore, let's say, even before you think about hormone replacement therapy. So I talk a lot about nutritional strategies. So one of the things that we know is very important for improving not just testosterone, but estrogen concentrations is your insulin levels. So if your insulin, and I would say insulin and your like adrenal health and your insulin, this is like if we think about like a pyramid, we want to be thinking about glucose and insulin regulation. And then we want to be thinking about adrenals kind of in step with that. But when you are consuming, let's say, a lower carbohydrate diet initially or transiently as like a nutritional therapeutic, let's say, you are going to improve your insulin sensitivity and very likely decrease inflammation through the body, which is going to allow for that free T to increase, because by way of lowering something called sex hormone binding globulin. So insulin directly affects the protein that binds up testosterone. So when we're having sort of a lower carbohydrate diet, let's say initially, not forever, ladies, but initially, I think that can really help with testosterone. Certainly weightlifting and lifting very heavy weights, I think, is another way to naturally increase total testosterone, which will, by way of just absolute number, also improve your free testosterone levels as well. And then your stress, right? Like we were talking about adrenal health and the kind of all of the sort of constraints that a typical woman in her 40s might be experiencing. But when you are in this hypercortisolemic state, you are absolutely going to also affect all of your sex hormones, not just testosterone, but you're going to affect progesterone, you're going to affect estrogens. And that's going to also affect your, your experience and your, we'll say, joy that you can experience in life as well. So those are kind of where those are the places that I play. It's like, what's the diet? What's the movement strategy and exercise regime maybe that this individual has? And then what's their stress management look like as well? So I think all of those things can make marked improvements in someone's testosterone. And then maybe they're doing that and they've mastered it and like, I still feel like crap, then we can say, okay, maybe now we can explore some bioidenticals and look and see how we can sort of augment what you're already doing right.
Yeah, very good point. I hope I didn't tell anyone to just jump right into, testosterone replacement therapy right away. So what you want to do is get it identified, get your diagnostics, your blood tests. But after that, you don't necessarily have to go on testosterone right away. So, like just like Dr. Stephanie is saying right now, behavioral modifications first. So look at your diet, look at weightlifting, like you said, is definitely a big one. And that's, there's the evidence for that is just undeniable. It definitely absolutely increases your total testosterone. And then maybe even after you've looked at behavioral modifications, you may want to look at supplementation. Now, I haven't looked at supplementation too much into women. I have looked at supplementation into men. You're probably very familiar with a lot of the protocols that Andrew Huberman has put out before. So, the two big ones that he talks about for increasing testosterone are Tungat Ali and then Fedosia. I'm not even going to try to pronounce the other part of that name, but those two in particular are the ones that seem to increase testosterone pretty effectively in men. I'm not sure. Are you aware, Dr. Steph, if those supplements are effective in women, or do you use them in women, or do you kind of stay away from supplementation?
I think that the honest answer is we don't know. I don't think that they've been studied appropriate. Like, I think that there's some evidence to suggest that there's some effectiveness in men. I think with women, we don't have the data. So it's kind of up to the clinician to play with and monitor, the individual to see if it's working for them. And the other thing that we want to be thinking about, of course, is androgen receptor, like the androgen receptor itself. So a lot of women are like, well, if I take TRT, am I going to lose all my hair? Right. So we want to understand sort of the other layer onto this is, do we want to understand the individual's genetic predisposition? So do they already have sort of androgen receptors that are like super active already and like kind of ready to bind up anything? So you give a woman DHEA and she's going to turn that into testosterone. And does she already have a genetic predisposition through an upregulation of, let's say, 5-alpha reductase to turn that into DHT or dihydrotestosterone, which for many of your men and many of your women listening, that's sort of like the super testosterone, right? It's like 6 to 7 times more potent than your run-of-the-mill, run-of-the-mill tea. But that can also cause sort of male or androgenic hair loss as well. So a lot of women are like, am I going to lose my hair? Because if I'm going to lose my hair, we have a conversation about that. And I think for men, we'll say, not that it's more acceptable to not have hair, but you can just buzz it, like you can just kind of buzz it like close
You
to
can
the,
still
like,
look good with a bald head. Like
totally.
at some point, I'm probably going to have a bald head, and that's okay. Like I'll be
Yeah.
okay with that.
Yeah, but I wouldn't be okay with that, right?
You
Like,
would
unless
I imagine most women would not be okay with
right.
that at all.
So there's kind of this extra layer of like, we'll call it vanity or aesthetic, right? Which is still also important to our psychological health as well. It's like, if
I agree.
I'm taking DHEA or I'm taking T, like what's going to happen? So we want to understand her the way that she metabolizes, let's say, her androgen and, her estrogen the way that she metabolizes her estrogens as well. So I would say that there's kind of that extra layer. So first, we don't have data, and then there's kind of this vanity question, right? Like, what's going to happen when we take TRT?
Absolutely. And I do want to move on to PMS bit, but just a couple important points that you made in there that I think are important for blood work. SHBG, I think, is another one that you should get tested as well, because just as Dr. Stephanie was saying, you can have high, or normal total testosterone, but then if you have high SHBG, or free testosterone, which is the one you want, is going to be very low. And then consequently, you're just not going to get the effects that you're looking for. So that's really important. And then also too, DHEA, because DHEA, again, try, behavioral modifications, just like we've talked about first. But if you have to go to, the prescription route, and actually DHEA, I think, is still over the counter in the United States anyway, but you can perhaps use DHEA first, even before testosterone, and potentially get the same benefit. So I just wanted to make that point before we moved on. But I know that, PMS is something that a lot of, women struggle with. They say that they're, great sometimes for 2 or 3 weeks out of the month, sometimes even just about the whole month, except for a few days. So, if a woman kind of has that typical presentation to you, what is your overall approach in treating them?
First is to figure out why it's happening. There are a few different reasons why it can be happening. So one, maybe the more common one, is unopposed estrogen in the second half of the cycle. So very briefly, a woman's cycle is approximately, the average is about 29 and a half days. So think about the lunar cycle or the moon cycle. Men are like the sun, like 24-hour kind of circadian rhythm, and women are more like the moon. So we go through sort of the symphony, we'll say, of our hormones over the course of about 29 days or so. So we have bleed week, which everybody knows. When you have your period, normal bleed is somewhere between 2 and 7 days. Second week of the cycle is sort of that pre-ovulatory week where we see a surge in estrogen, a surge in testosterone, a surge in a few other hormones, luteinizing hormone, which will eventually, like the whole point of your cycle is to ovulate. It's not to bleed. So the ladies that are listening, the point of your cycle is not your period. The point of your cycle is to ovulate. It's reproduction, whether or not you want babies. That's like what your biology is doing. So the ovulation is basically a release of the egg from the follicle, and that marks the beginning of the luteal phase, which is the second half of the cycle. For most women, it lasts anywhere from 12 to 16 days. So it's a little bit longer than the follicular phase. And it's usually in that second half of the cycle where we can see a lot of issues. So when we release the egg, what should happen is that progesterone should rise, and it should rise higher than our estrogen level. So estrogen has two peaks. One is in the follicular phase, and then it has a second lower peak in the luteal phase of the cycle. For many women, again, thinking about some of the environmental stressors that we were talking about, the children, the aging parents, you layer on environmental toxicants. So you think about plastics, and that includes when you go and get your Starbucks, ladies, take the damn plastic thing off of the top. Doesn't matter that the cup is recycled. If you're sipping that hot coffee through the plastic, you're getting some of those BPAs that are in, and all the kind of other stuff, the other BPs that are in that plastic cup as well. Don't take receipts from your grocer. When she gives you the receipt, tell her to put it in the bag or just discard it entirely. Plastics also very well known, very well documented, endocrine disrupting chemicals, which can cause an increase in estrogens. The reason why I'm telling you about the plastic lid and the plastic Tupperware and, you know, the receipts at the grocer or wherever whenever they give you a receipt at a shop, is because they can cause what's called estrogen dominance in the luteal phase of the cycle. So what that means is that estrogen rises higher than progesterone. When we think about what estrogen does, it's an anabolic hormone, right? So it is going to cause cell proliferation and growth. So cue in the tender, angry breasts, right? So it will continue to stimulate the estrogen receptors in cells like the breast. So we have unregulated, cell division and growth in the breast. That's never something that we want. And then we also have, by the same token, and maybe more deleteriously perhaps, it shuts down osteoblastic growth, let's say, in the bone. So what that means is that your bones your bones in your skeleton throughout your body are constantly remodeling themselves, right? So it takes about an average of 2, depending on how old you are, 2 to 4 years, we'll say, to completely turn over your skeletal system. When you shut down osteoblastic activity, these are the bone cells that are involved in growth. You have osteoclastic activity that can take over, which are the cells that sort of denigrate and break down bone. So over the course of time, net, if you're running estrogen dominant all the time, you're going to have really tender and angry breasts, and you're going to run the risk of driving your skeletal system into more of an osteopenic state. And eventually that turns into osteoporosis, which none of us want. So,
appreciate you explaining that, by the way. That was very, very good explanation. Go ahead.
Thank you. Yeah. So I would say that that's one of the main reasons why a woman will experience PMS. The other reason, and then that leads to, so when we have high estrogen levels, that's going to lead to really heavy periods, like when we look at the quality of the blood flow, there's going to be lots of clots. She's going to experience lots of cramping because there's going to be an upregulation of prostaglandin activity. There's several other reasons why. That's kind of one of the big ones, is estrogen dominance. Thyroid, so hypothyroid function. Also thyroid and estrogen, they're kind of like twinsies, right? When we have the thyroid is not functioning in the way that it should. Of course, the role of the thyroid, it's a major endocrine gland in metabolism, is to get substrate into the cells, right? So when you don't have enough active thyroid hormone, which is T3, you're also going to experience some of these estrogen excess symptoms that we were just talking about. So like the tender, angry breasts, the really heavy bleeding, lots of clotting,
Bloating
and
and headaches too, I find a lot too.
exactly, lots of brain fog, lots of puffiness and swelling, like very pro-inflammatory, right? So whenever a woman is experiencing PMS, we want to ask, okay, so what are the hormones doing? What is she eating? Because one of the beautiful things about estrogen dominance and even thyroid dysregulation is that it is very receptive to certain modifications in the diet. So, for example, when we're thinking about optimizing estrogen metabolism, or estrogens, I should say more accurately, we want to be thinking about consuming more green leafy vegetables, or even supplementing with compounds that have, supplementing with sulforaphanes, or even if someone has estrogen excess, supplementing with a diindole methane, or DIM is what the cool cats call it. So it's DIM would be the supplement. So when we're thinking about green leafy vegetables, it's like it's the broccoli, it's the cabbage, it's the kale, it's the spinach, it's the arugula. For those of you like, but what about oxalates? Because that's always the next question that I get. Just steam your veg. It gets rid of like 80 to 90% of like those do like kale. And if you're having a lot of raw kale, certainly we want to be watching the thyroid, because oxalate, like it does impact the thyroid when all you're having is like a cold kale salad every single day. But steaming most of these green leafy vegetables, you're going to preserve, quick, like flash steaming them, right? Like not, whenever I remember I'm going to call out my mother-in-law here. Sometimes like she'll serve broccoli and it's just like this limp, really sad looking broccoli that's been boiled for 40 minutes. It's like, there's nothing here. This is just a shell of, something that used to be healthy. But just like flash steam, right? Like flash steam something. So you can preserve a lot of the sulforaphanes, the DIM, but you can reduce some of that oxalates if you're sensitive to it. And I will also say that most of the population can handle oxalates just fine, right? So
yeah, I think
most of us are just fine. Yeah.
I think that was kind of like an overscare for a little bit. I think Dr. Rhonda Patrick actually went over that pretty good a few times and said that they're not as, harmful as we kind of think, but at the same time too, yeah, like don't be eating raw kale all the time, because, that can absolutely impact your overall thyroid function, which is, obviously very harmful. And that's just going to make your symptoms and everything significantly worse.
Yeah, totally. I'm so glad that she did that, because it's like, we're not eating enough vegetables as it is. And there's, individuals who will remain nameless. It doesn't matter who they are, but it's like, they're like, don't eat vegetables. They're the worst. They're going to kill you. They hate you. It's like, well, they're really doing a really poor job of killing us. Like they've been around forever. We're kind of an omnivorous species where we are well designed to extract minerals and nutrients and vitamins from our meats and from our plants. So,
No, I agree with you. Like there's lots of things that I think that are great about Carnivore MD or Paul Saladino, not to pick on anybody, but
I've had him on the show too. He's very like a great speaker. I'll say he's a great orator.
Yeah, and again, like I'm not, shitting on him in particular. I think again he's done a lot of good and has educated a lot of people. But one thing that I guess take issue with, not specifically with Paul, just in general, is that when people kind of look at mechanistic studies and say that there's anti-nutrients in these vegetables, and they talk about lectins as well and that kind of thing. I understand that, and like I see the rationale behind those studies, but if you look at humans, human studies, show me a human study where you give vegetables to someone and things get worse. Almost, unquestionably, if you give 5 servings of fruits and vegetables to someone per day, everything generally improves. And beyond that, I will say, the data does decrease a little bit. It's kind of like the 10,000 steps. Like once you get there, maybe going to 12,000 might give you a little bit further. But then after that, the kind of returns sort of diminish a little bit. And then for fruits and vegetables, like getting up to 5, like so going from 1 to 2 to 3 to 4 to 5 does seem to have a pretty good impact overall on your longevity for, decreasing things like cancer and even just overall all-cause mortality. But I think once you go beyond 5, it kind of diminishes a little bit. So maybe you're getting some benefit, but it does decrease. But getting up to 4 to 5 servings a day, I mean, you should really try to strive to do that, I think, every day. If you miss 1 or 2 days, don't worry about it too much. But I think that is an important point, that people should be trying to eat 4 to 5 servings of fruits and vegetables a day, and don't be afraid of this like anti-nutrient nonsense that a lot of people are spouting out there.
Yeah. Yeah. And I'm laughing a little bit because you went right to Paul. It's like some of these people online who remain unnamed, and you just were like, well, these guys like Paul's all the time. And also, so I will say, like, Paul is, as I mentioned, great speaker. One of my constructive criticisms of his work is kind of what you said, that he will pull mechanistic data that he'll talk a lot about like epidemiology is terrible and it's the worst, and then he'll cite an epidemiological study to sort of prove a point. So that would be my constructive criticism of him. I think that I think that we can do better, and I think that we are designed to eat vegetables. And particularly for women, when we're thinking about kind of back to what we were talking about, this PMS, like, one of the best things that you can do to improve estrogen metabolism through, we won't get into it because it's just too nerdy and boring, but like the hydroxylation and conjugation and elimination sort of pathways through the liver is actually these sulforaphane and these DIM containing compounds. So you can improve the function of your liver, which is actually very important for estrogen metabolism. It'll improve your gut, right? So the fiber that's contained in those green leafy vegetables, if you're having the whole vegetable, is going to provide a lot of roughage. It's going to, bulk up the stool. You're going to improve the estrobolome, which is an area in the gut that is completely just dedicated to estrogen metabolism. Like, how freaking cool is that? So, the more green leafy vegetables that we're consuming, you are going to also help with estrogen elimination, because kind of the golden rule of estrogen is use it and then lose it. We don't want it hanging around, or else it's going to have some of those like deleterious effects that I was just mentioning, like the breast cell proliferation and growth and shutting down of our, bone remodeling. And that's really important for women, right? We want to be thinking about when we're in our 40s and 50s. Certainly, we want to be thinking about bone strength. We want to be thinking about muscle improving, at least maintaining, I should say, what we have at the very minimum, but ideally adding to the lean muscle mass that we have. Again, that's partially under the control of estrogen too. So improving estrogen metabolism is going to go a long way to helping not only with a woman's PMS and like the symptoms that she may experience in the luteal phase of her cycle, but also just her enjoyment of life, right? Because who wants to hug anyone? Like, I wrote about this in my book. I used to run very estrogen dominant. I had to take days off of like the first, day or two, let's say, before my period. And then even the day of when it started, I had to take time off. I couldn't engage in like my activities of daily living. I had to like medicate myself to, someone might like is an expression I'll use, like, I was medicated up to the tits, right? Like, I was like all the way, like medicated all the way up because I couldn't handle the pain. But a lot of that is modifiable with diet. So that's like the really great news. It's like, okay, so if I can really improve the way that my body deals with some of these hormones by introducing a stimulus like a green leafy vegetable to improve it. And there are products, of course, that have come on. I don't know if you do any sponsorship or anything like that, but one of the products that I really like is Athletic Greens. So if you're not able to, there are many, like not it's not only that one, but there are many greens products on the market where maybe you can't flash, saute your broccoli that day or whatever, and you just put a scoop of this green stuff in your water. It tastes great, or you mix it in with a shake or whatever it is, and then you get your greens, with some of those compounds that we've been talking about, to sort of help with that detoxification and estrogen metabolism as well.
Okay, excellent. So just to kind of give people, I guess, a few sort of like hard strategies in terms of how to balance their hormones in the second half of their cycle and decrease their PMS symptoms. Number one, green leafy vegetables for sure.
For sure.
What would be a couple other strategies that you may use to decrease their symptoms?
I would say anything where you're increasing movement and exposure to sunlight. So
Okay.
first thing, kind of Huberman, very well known for his discussion around
Sunlight. Yeah.
sunlight, right? Very well known
Yeah.
for early morning sunlight. Of course, that is and I like the way he I was listening to it's a very old podcast that he had put out. He's like, I know it's kind of like new agey to say go out in the sunlight, it'll balance your hormones, but it really
Yeah.
does, when you breathe through your nose, it's going to balance your hormones. And it sort of sounds like, someone from, no disrespect, but like someone from, Encinitas or something,
Yeah.
California or someone.
No, but
And
he put out something yesterday, actually. I was really surprised. I don't know, I shouldn't be too surprised, but about breathing technique where
oh, cool.
I
Yeah,
forget
cool.
exactly what it was, but or what it was called, but basically it was two like nose inhale, so like, and then exhale through your mouth. And
Like
then
a
he said,
physiological sigh, like the
yeah,
physiological sigh.
and he
Yeah.
said that was actually improved overall health or reduced stress better than mindfulness meditation or meditation. Don't quote me too much on that, but just go to Huberman's page, you'll see it there. But that's pretty accurate of what I just said. But you may want to check out all the details. Just go to his page. But that's where I think that we can also do some improvements as well with regards to behavioral modifications. Is when you think behavioral modification, basically you kind of, most people think like diet and exercise, maybe supplementation, but they don't necessarily always think of like the things that you just mentioned, which are like sunlight. Like that is something that I have really honed down on over the last year. And unfortunately, I live in Ontario like you, we don't really get too much good sunlight in the morning, and it's kind of shitty to go outside when it's like -10 out, even if there
It's
is
free
sun.
cryo. That's how I
Yeah.
look at it. That's how I justify it. Like I don't have to buy cryotherapy. I don't have to have it. I just can go outside in the freezing cold weather in a tank top and I get my dopamine.
Yeah.
At least that's how I'm explaining it to myself. Yep.
No, it's definitely helps. I mean, you're doubling down when you do that, because obviously the cold in the morning, as you said, gets you that dopamine stimulation, and then the sunlight, seems to be incredible for regulating your circadian rhythm and for sleep. So
Yeah.
very, very good. And then just one more point on that, like if all of Stephanie's strategies, for whatever reason, don't alleviate all of your symptoms, something that you may be able to consider. I'm not sure if some of your clients do this, is you can take a little bit of progesterone just on days, say 15 to 25 or 16 to 20. I have some patients that do that, and they do find it to be very helpful, and not so much in regulating hormones. My next strategy is sometimes CBD oil can be effective, but again, like that's just mitigating symptoms. It's not, treating the underlying cause per se. It's just like, using CBD oil instead of Advil. Like I don't like using Advil for, a lot of different reasons. It can be hard on your kidneys. It can even increase the risk of heart attack, even if you use it in the short term. And that goes with all NSAIDs, so non-steroidal anti-inflammatory drugs. But we also know that, they can in fact be pretty effective for reducing some symptoms of pain and headache and that kind of thing.
Yeah. And I would, the only comment I would make there is the progesterone therapy. You want to make sure that you're caring for a progesterone deficiency, not just trying to increase total progesterone to make it higher than estrogen, when you can be pulling back the estrogen. Again, coming back to hair loss,
Yes.
like women are like, I don't want to lose my hair. So
Yeah.
if you're inappropriately, I have women ask me all the time about bioidenticals. This is a question that is like, what do we do? And, we won't get into the Women's Health Initiative, which was we'll just call it what it is, a botched study, the most expensive dud of a study that was ever done. And unfortunately I don't think will ever be repeated. But there are no real standards for protocols for bioidenticals and even HRT, right?
Mm-hmm.
I think we're all really leaning on our clinical experience and the patterns that we see in the patient base that we're serving, because there isn't a lot of standard protocols for it, right? And like, progesterone, if you are inappropriately dosing progesterone. So the question that always comes to me is like, I'm 34 or I'm 42. Should I prophylactically start taking progesterone? Because I know that my progesterone is going to lower. So should I preventatively, maybe that's a better word, should I preventatively start taking progesterone because I know it's going to lower as a function of age? And it's like, well, if you are inappropriately dosing, if you're not taking progesterone appropriately, you can start to have what's called progesterone resistance, right? So if you're taking too much too often in the wrong time of your cycle, or you don't even qualify for the diagnosis of low progesterone, you can start to run into progesterone resistance in the same way that diabetics run into insulin resistance, hence the need for higher and higher insulin over time because the body habituates to it. Now, why I'm bringing up hair loss is we all know the pregnant woman, she's got progesterone coming out the wazoo and her hair is like a Pantene commercial, right? It's like thick and whatever. She gives birth and what happens? Progesterone drops and all of her hair like comes out. Like women tell me all the time, and I had that experience as well. Like, my hair walked into the room like 2 minutes before I did, right? And then after I gave birth, it was like all of that kind of went away. And if you inappropriately have or artificially have too high levels of progesterone in a woman, at least you can prevent, you will shut down the receptors in the hair follicle, which will cause them to be inactive and unresponsive to anything. And then you can also see some hair shedding as well. So again, maybe not as big of a consideration for men, because like I said, buzz cut and we're good. But for women, this is a big concern, especially in perimenopause as well, because we already have fluctuating hormones. We're already seeing a lower estrogen environment. We're already seeing a lower testosterone environment, lower progesterone environment. So we're already seeing some hair thinning out. So we can be a bit more, we'll say, exquisitely sensitive to some of these changes in hormone levels.
Yeah, you definitely don't want to mess with a girl's hair loss. That's
No.
definitely something that that needs to be
Ask
avoided
any
at all
hairdresser,
costs.
right? Like a girl goes in for a trim and she's like, just this much. I just want this much hair. And the hairdresser ends up chopping up more than that because like her hair is dead, but she won't give it up, right? So
Yeah, it's definitely something that I definitely want to avoid is, treating a woman and then having her hair fall out. That's definitely a nightmare for me. So I know we only have a couple minutes left. We probably won't be able to get into it too much, but if a woman comes to you and they have trouble with sleep, which I know is very, very common,
huge. Yeah.
and again, I know we only have a couple minutes, but what is sort of your overall approach to that? And I know you have to, again, treat the patient holistically from up to down and asking them, why is this issue in the first place? But what are sort of your cold notes versions if you can?
Yeah. So all the things that you just said as sort of a preamble, like we want to understand the person's situation and, kind of what's going on, I would definitely be testing. But some of the natural solutions that someone might consider would be actually what we were just talking about, sunlight. So your sleep starts with what you do first thing in the morning. So can we get some early morning sunlight where the sun is at a low solar angle? You're getting that kind of blue light, which I know has been kind of demonized a little bit, but blue light in the morning is actually it's an appropriate stimulus. It typically, I had Dr. Michael Bruce on my show, and he was talking about this timer that happens when we're exposed to early morning light. So there's this timer, like somewhere between 14 and 16 hours, that once the brain perceives this early morning light, it's like, okay, so I'm going to get going. And then like 14 to 16 hours later, I'm going to be sleepy, right? So it's kind of like this like internal timer that starts. So that would be the first thing. If coffee's another one. So we all like our warm brown water, right? I love my warm brown water in the morning, my coffee first thing in the morning. I typically have it outside, actually. I like to, right now, it's at least at the time of this recording, it's spring-ish in Toronto. So we got birds, sounds like sometimes I feel like I'm in, Puerto Rico because there's so many birds in the morning, but I'll go out and I'll listen to the birds sing and stuff. But I'll do that with like an espresso or cappuccino or whatever in the morning. We want to be thinking about caffeine consumption, because caffeine, as you very well know, Mike, has a very long half-life, and depending on your genetics, you might be able to metabolize it a little faster, a little slower. But if you are, typically the advice I have to sort of optimize sleep is to cut coffee off at about 12. Like, so have a cup or two, but nothing past 12 p.m. Because that's going to affect your ability to fall asleep. And there's another hormone we won't get into called adenosine. It's going to sort of occupy the receptors for adenosine for longer than it should if you're consuming coffee, let's say late in the day. So there's coffee, there's early morning sunlight. In the evening, certainly, the TV seems to be okay, but it's really like the computer work and the phone use that is more, so that's that blue light that we can use during the day, which is fine. But then as the sun goes down, we want to be exposing ourselves to more red lights, yellow lights, orange lights. So think about the sunset, right? The sunset has those beautiful hues. It's like the pinks and the blues and the reds, that kind of, like, when you see the sun is sort of beautiful and colorful in the sky. Which means, unfortunately, that Instagram and emails and all the things that you do on your phone, let's say your banking, whatever, has to stop after a certain point, because it is going to, you're looking at that with your eyes, which is connected to that master clock that perceives the blue light, and you are going to inhibit the production of melatonin. In terms of supplementation, if we're thinking about stress, in the evening, I like phosphatidylserine. I like ashwagandha. Rhodiola is another good one, but it's better to take that during the day, not necessarily at night, because it can be activating for some people.
Mm-hmm.
Let me think what else. There is a product that I really like. It sells out all the time on Amazon. It's called Cortisol Manager.
Okay.
I believe the company is called Integrative Therapeutics. It's their bestseller. It's an awesome product. It has all the things. It has some ashwagandha. It has L-theanine, which I didn't mention. It has phosphatidylserine. All of these things that are very calming to the nervous system, that are kind of bringing you into.
Does it have Relora? Do you know? Relora is one that's been shown to reduce cortisol, and that's one that I actually take a lot actually after I work out, because I usually work out like after work. It's not before work, so it's like not right before bed. But if I tend to work out somewhere between about 5 to 7, and then I probably go to bed somewhere between about 10:30 to 11. So it's not like directly, I don't work out directly before I go to bed, but still fairly close time. So that's something
I don't know offhand. I'd have to look at the label, but yeah. So that's a product that I really like. No affiliation, but I often recommend it. So those are some of the things that I would think about in terms of supplementation. If you are someone who's noticing that your chronotype is changing. So that's, again, Dr. Michael Bruce's work, where he talks about, like, are you a bear? Are you a lion? Are you like
the dolphin?
Yeah, the dolphin, all that. So he talks about this age change at about 52, 53, where you will revert to a different chronotype. So supplementation with melatonin might be appropriate at that time, as well. If let's say you were, like, I'm very much, I think I'm a lion, which is I like to go to bed at about 9 o'clock, and I like to be up at about 4:30 or 5. And then that might shift for me, when I'm moving in through my 50s, right? So we might think about, melatonin supplementation, let's say, at that time. So that's something else to consider as well. And he has a lot of great books. I think his website is The Sleep Doctor.
Yeah.
So much awesome information on that website. He reviews mattresses and all this. He's great. Does a lot of work. Does a lot of free work.
That was an incredible recap of how to sleep well in just 5 minutes. So I really appreciate that.
Thank you.
I'm so sorry to do this, but unfortunately we're kind of out of time here. So Dr. Steph, where can people buy your book? Where can they learn about your podcast? How can they work with you? Can you share all that information with us?
Sure. Well, if you're listening to this podcast, you can listen to mine as well. It's called Better with Dr. Stephanie, probably on the same platforms like iTunes, Spotify, and all the places. And you can buy my book, Amazon, Barnes and Noble, kind of like wherever books are sold. And then you can find me on Instagram. I try to be as active on there as I can. Sometimes I get backed up with client work and things like that, but I'm usually posting there a couple of times a week. So you can find me at Dr. Stephanie Estima on Instagram as well.
Awesome. Well, it was amazing chatting with you. I'd love to have you back on the show, because there's definitely some topics that we didn't get into that I wanted to, but we definitely covered a lot of good ground here today. So thank you so much for coming on. Thank you so much, everyone, for listening. And as always, I'll be back again next week.